Hello, everyone, and welcome to today's webinar. I am Winnie Sibilak, and I'm the Senior Marketing Manager here at Draeger. It is my pleasure today to introduce you to our speaker, Rob DeBlasi. Rob is the Manager of Research in the Respiratory Therapy Department and the Manager of the Respiratory Translational Research and Aerosol Lab at Seattle Children's Research Institute. Over the last 10 years, Rob and his team have conducted research to evaluate nebulizer efficiency, delivered lung dose, and depositional losses with several liquid and dry powder aerosolized surfactant delivery systems for both RDS and PARDS. Other preclinical research from the lab has focused on evaluating physiologic outcomes on pulmonary mechanics, gas exchange, pulmonary inflammation and injury, histopathology, work of breathing, and the electrical impedance tomography with different inhaled therapies and forms of neonatal invasive and non-invasive support. Real exciting stuff coming out of this lab. And Rob and his team, I applaud you for all the work that you've been doing and continue to do. Clinical research is currently focused on working with industry leaders to evaluate novel devices and therapies for the neonatal patient population. Well, let's go ahead and welcome our speaker today. I'm so excited to have Rob DeBlasi be able to speak about using neonatal airway graphics to optimize care for the neonatal patient.
All right, I'm going to go to the full screen view.
Thank you.
And get my laser pointer ready because, if you're going to give a graphics talk, you got to have a laser pointer so that you can point out all the different flow patterns and pressure patterns. Thank you so much for the introduction. I really appreciate it. And any day that I can get outside of a lab and actually engage with a group of people outside of my clinical duties, which are usually on Fridays, is a day well spent. And so I'm actually particularly excited to have a discussion with you on neonatal and pediatric airway graphics and waveforms. I've done this previously, but I continuously update all of our slides based on kind of new, complicated, and challenging patients. And let's face it, right? I think we can all agree that neonatal pediatric patients are some of the most complex patients that we could potentially support, especially when it comes to mechanical ventilation. And there's so many different diseases and different underlying pathophysiologies that we deal with on a day-to-day basis, especially working in children's hospitals where, we could be resuscitating or supporting a low birth weight preemie with thumb-sized lungs and then run next door and do the same in someone my size. And so, obviously, as neonatal respiratory therapists, we are challenged by all of these different patient sizes and different diseases. And, so I'd like to share with you kind of an overview and summary of what, I would consider normal airway graphics, and then, dive into what abnormal airway graphics are going to look like. And so these here, I'm just going to move this over. Hopefully you can all see my screen still. These are basically my disclosures. Draeger is sponsoring this lecture. I've received honoraria or research funding from multiple organizations, which include Draeger Medical, Medtronic, Vapotherm, Benel. Like I said, the majority, or like Winnie said, the majority of our research is industry funded. And, we need to have more labs like that who are, discussing new devices, new technologies. So with that being said, we're going to talk today, these are our objectives, and we're going to talk about how to evaluate the normal and abnormal lung physiology based on using graphics. And so, we'll talk about what constitutes a normal breath, abnormal breath, how to make your graphics look better based on, the artifact that you could observe based on the water or, a flow sensor that's not working well. And then we're going to really dive into, unlike other graphics lectures, this one's going to be less basic. It's going to dive into kind of the future of lung monitoring in babies and how we'll be able to evaluate these different therapies and interventions that we constantly have introduced to the neonatal care environment. And so there'll be a little bit of pediatric sharing as well, on airway graphics, but I would say that for the most part, this is limited to neonatal. And so most of you wake up in the morning, you come into the ICU or wherever you may work, and you see this. You have a baby who's critically ill. That baby may be on significant support, whether it's inotropes or inhaled nitric oxide. And here at the kind of center of everything is a mechanical ventilator. And so this baby right here is really trying to tell us something based on all of the different monitoring abilities and tools that allow us to diagnose in real time what may be going on from breath to breath related to the patient's disease. Obviously, we have x-rays. That's a snapshot that allows us to kind of evaluate maybe where the tube is placed. Some people might like to look at that for lung volume assessment. But again, it's a poor kind of diagnostic tool for determining the overall current state of patients that are on a ventilator. Right here, and every single ventilator, believe it or not, that's FDA approved, that's being used in an intensive care setting, hopefully has some airway graphics. Now, airway graphics, I think to a lot of people, it may just be something that you look at outside the room to determine if the baby's connected to the ventilator and is breathing appropriately. And I often say, the people who become the true artists are the physiologists in interpreting what's going on with your patient, because this patient's trying to tell you something. And it could be something that could happen later or something that's existing in the current state. These airway graphics, especially in neonates, can be measured either back at the ventilator or at the patient. And in any situation that you have a mechanical ventilator that incorporates a proximal flow sensor, I would say that it would be very important to actually integrate that, use that, make it work. I know sometimes it can be a pain, but if you want to become an expert at airway graphics, you in fact have to be able to measure those flows and those volumes right there at the patient. Pressure is always measured within the ventilator back here. And so even when you're using mechanical ventilators that have a tubing compliance factor that's integrated and accounts for the compliance within the circuit and the compressible volume loss, there's bound to be some artifact, but in time, the compliance that you have set within that ventilator based on your initial use check could actually not always reflect what the compliance of that circuit is over time. So the compliance of the circuit is going to change over time as it warms up and as you expose that ventilator circuit or patient circuit to pressure. And so if you are not using a proximal flow sensor, I would definitely suggest that you calibrate often because there is some good data showing that in time, the volumes, the pressures, the flow, everything could be affected, and you're just better off using a proximal flow sensor, in my opinion. The approaches to invasive ventilation, really, these are the kind of the key tenets by which we practice neonatal mechanical ventilation. And I kind of shamelessly stole this from my friend Evan Richards. Everybody knows Evan. And, so he worked with Bunnell. And in a textbook chapter, he stated that all the respiratory therapists or clinicians managing ventilators have to know the ventilator and the disease, the underlying disease that patient's experiencing. So the underlying pathophysiology. We have to come up with specific strategies for, treating these individual patients. And not everybody's going to fall under, the cookie cutter umbrella of the different diseases we see in the NICU. Everybody's going to be different. And from one moment to the next, that patient can change the ventilator strategy as the pathophysiology changes. And so really, in order to do that, we have to rely upon graphics. Patients trying to tell us something. Always try to wean your patient off the ventilator. And so if you're trying to wean your patient off the mechanical ventilator, you have to actually rely on your graphics, and you have to listen to what that patient's trying to tell you. And so the key messages that I really have for you is that, and we don't measure these things necessarily in the NICU, but we're going to talk about ways that you can. But increased work of breathing and poor gas exchange are really the two very important clinical factors that identify pulmonary function, but they also contribute drastically to respiratory failure, and they kind of corroborate our findings of respiratory failure and the ongoing need for mechanical ventilation in infants and children. And so the inability to provide patient synchronized ventilation has really been associated with major consequences. And, this could lead to increased usage of neuromuscular blockade, heavy sedation, which we all know that keeps the patient on the ventilator longer. And the longer they're on the ventilator, the more they are prone to developing injury and inflammation. And so, the biggest thing, like I mentioned in my previous slide, is that we want to get that patient off as soon as possible. And so if we can identify dysynchrony, asynchrony, or poor patient ventilator interaction, then, I think that right there is a beautiful form of lung protection, right? And so, whether you realize it or not, there are things that you can do to change the course of the patient, whether it's a simple ventilator manipulation or you give inhaled medication or surfactant. There are ways that we can track all of these things to determine if there was a successful outcome based on that patient's lung mechanics and airway graphics. And so, like I said, and I'll say it again a couple of times during this lecture, a true physiologist understands the underlying pathophysiology, but they also use these airway graphics and they integrate that into their daily care to be able to support these patients appropriately. And so there's really no good data to speak of that really, speak to the improved outcomes with assessing graphics. No one's ever really done that. It would be nice to have some of those data, but I can tell you firsthand that the first thing that I do when I walk in the patient's room, when I get called on a Friday to go up there and look at patients, is, I obviously look at the patient, but then I look at the airway graphics, and almost right away I'll be able to determine, what could potentially be going on. You have to kind of put all of these little puzzle pieces together and look at your monitored values, look at how they're breathing, look at, what their airway graphics are trying to tell you. And so we can identify early on some of the processes that lead to changes in pathophysiology and the patient's underlying condition. We can adjust the ventilator and fine-tune the ventilator. It's our tool. It's a bridge to support the patient, but really, ultimately, it is up to the clinician, respiratory therapists or physicians to identify, and even nurses, to identify, whether a patient's not doing well, and, be able to look at the graphics. I mean, we'll go up there with the thumb drive and we'll grab these graphics in real time and then fine-tune the ventilator, and then, use those graphics to share with people so that they can understand that, there are simple manipulations that you can make in order to improve the patient's interaction with the ventilator. So obviously, we're using these graphics to determine the effectiveness of the ventilation support, look at maybe early detection versus, adverse events of mechanical ventilation. We know that we're giving, humidity, we're giving aerosol. How do we know when you look at these graphics, how do we know that, what we're looking at is not something that's going on in the circuit versus in the patient's lungs? And so it's important to separate those and obviously minimize the risk of ventilator-induced complications and ventilator malfunction in the end. And so the respiratory equation of motion guides everything. The change in pressure that occurs in the lung, known as the transpulmonary pressure, is really, going to be equal to the airway resistance times the flow plus the compliance, or it's volume over compliance, sorry. And, you have to consider that when we consider the pressures, and sometimes those pressures are high, that increased airway resistance could be the airways, but it could also be the endotracheal tube. And when that compliance is low, so it's volume over compliance, sorry for the typo, we have to also realize that, this could be the effect of, especially when compliance has become reduced, it could be the effect of the actual lung, but it could also be the chest wall. And so airway pressures really, are important to track and trend, but the airway pressure does not necessarily reflect truly what's going on in the lung. So what's being measured? We're measuring real-time accurate waveforms, and hopefully they're accurate, and we'll talk about ways that you can kind of mitigate some of the noise or inaccuracies that may occur while you're ventilating patients. We have proximal airway pressure. So these are the pressure in time, the inspiratory and expiratory flow rate in time, and the inspiratory and expiratory rate, expiratory tidal volume over time as well. And so in addition, so for a single breath, you have all of these things. Loops are going to represent the pressure volume relationship that is more, correlated with your compliance. which again is going to be your lung and your chest wall, and also the flow volume loop. And that can tell us a lot about how the gas is going in and how the gas is coming out of the lung. So these are typical normal scalar waveforms, right? And I would say in the NICU, we always use pretty much a decelerating waveform pattern. We'll use pressure control, or we'll use volume targeted mechanical ventilation. And so for a single breath, we have this increase in pressure. Start a breath. It's how many, how much, and how long, right? So basically how long we hold in that breath in the lung, that's determined by the inspiratory time. If you're in pressure support, it's determined by a certain percentage of the peak flow. And, you know, obviously this patient is receiving some PEEP. So this is what your pressure looks like in time. So we have multiple breaths. This is your flow. Decelerating wave flow pattern, which is consistent with pressure control. If you're using volume ventilation with a fixed flow, which is not commonly used in the NICU, then you're going to see more of a square wave flow pattern here, and you're going to see more of a shark fin type pressure in this instance, and volume usually looks pretty similar across the board. And so these are the loops. We have pressure volume loop, and this looks at the association between, you know, what airway pressure is required in order to open the lung. And these are fairly normal, but I suspect that these are graphics that we obtained or acquired in a patient back at the ventilator versus, you know, using a proximal flow sensor. And so if you look here, I think that's the pediatric mode. So you see a lot of kind of, these are normal, but keep in mind that you're seeing a lot of kind of peaks here. You got this little peak. This probably represents a lot of the circuit artifact that's going on in the lung. However, we have ways that we can assess the pressure volume loop at the airway, which I think is important. These are fairly normal. You know, the compliance curve is kind of sitting up. It should always look like a football that's ready to be kicked ready to be kicked. And then this is the flow volume loop: inspiratory flow in, expiratory flow out. You see here that, you know, there may be a little more time for inhalation to occur to fill the lung in this pressure control mode. Exhalation is always going to be passive, whereas inhalation is going to be active. And you see that the patient almost exhales down to baseline. So relatively normal overall with regard to this graphic. So again, keep in mind, you get pressure, you get flow, and you get tidal volume in time, but then you have these flow volume and pressure volume loops that you can allude to. And so these are the different modes that are commonly used in the NICU setting. Pressure assist control, you know, again, square pressure waveform, decelerating inspiratory flow waveform. I would think that this patient probably had a little bit of a prolonged inspiratory time, because what goes in must come out, and you don't really want to hold it in there. That may be good for someone who's heavily sedated, but not necessarily for someone who's breathing spontaneously. Pressure SIMV, obviously that's a mixed mode between a higher peak inspiratory pressure with the mandatory breath. And I guess that all really depends on, you know, what mode you're using or what breath type you're using with pressure control SIMV. But again, that's kind of a mixed mode of assisted and spontaneous breaths. The brown in this lecture is going to represent spontaneous breathing, spontaneous triggered breaths, and then the blue is going to represent the mechanical breaths that are being assisted or being provided by the ventilator based on the inspiratory time. Pressure control, PSV, again, that's slightly different from pressure control AC, and that has to do with the fact that instead of setting an inspiratory time in this case, the flow is actually going to cycle based on a certain percentage of the peak inspiratory flow. So there's a little more natural. Patients can determine and predict their own inspiratory time, but not widely used without a volume targeted mode in the NICU, at least nowadays. And I think that has to do a lot with leaky tubes, but also you know, with the fact that, you know, we probably would put a patient for short-term assessment of spontaneous respiratory drive into this mode, just to kind of find out what they're doing. And so those are kind of the primary modes that we use. You have to improve the quality of your graphics. And so this actually is something that I sent out the other day to our staff, where there was a patient who was having excessive fluid accumulation in the circuit, was getting inhaled bronchodilators, and was, you know, placed into a pediatric circuit. The patient was 7.5 kilos, and it's pretty standard that we're going to use an infant circuit there. but it's nice to be able to allow them to synchronize and remove the flow sensor, obviously, when you're giving a bronchodilator. But there were cases where, maybe we didn't put the flow sensor back in, but they were still able to trigger. Nonetheless, if you are to evaluate graphics in the absence of a proximal flow sensor, you're going to get a lot of artifact. And so your pressure volume loops, that right there looks like something I'm not super familiar with. You're going to get flows that are kind of doing this figure 8. So you get a lot of artifact because you're not measuring with a proximal flow sensor at the airway. But even more so, the tidal volumes that are being measured back at the ventilator based on a tubing compliance factor that may have been set days ago don't necessarily reflect what the actual tidal volume is that's being delivered to the patient. So, there's maybe 25, 30% higher tidal volumes when you use a proximal flow sensor. The graphics are much cleaner. The patient's able to trigger more of the breaths because of the proximal flow sensor. And, you can see that the respiratory rate's a little bit higher. And so patients actually truly do better with proximal flow sensors, even though you have that tubing compliance factor without it. Some ventilators are better than others, but, I always try to support the use of a proximal flow sensor. But also you need to evaluate equipment and make sure that your equipment is functioning properly. So this is a patient who actually appeared to have just mild gas trapping. And by going into the room and looking at the patient, removing the proximal flow sensor, shaking the water out, and then maybe replacing the cable, or more so the proximal flow sensor, you get a better airway graphic. So this is really just based on changing the flow sensor out and recalibrating it. And so we've shown that in time, you get a lot of kind of gunk that builds up on the proximal hot wire flow sensor. And, so it's important to maintain your flow sensors appropriately so that you're getting meaningful graphics and meaningful data. Always make sure that, what you're looking at is the patient and not the patient, the circuit, or both. And so this is a situation where a patient had excessive fluid accumulation from humidity building up in the circuit, and that condensation resulted in a lot of like jagged airway graphics. And I said, well, is there some way that maybe we could improve the quality of the graphics? And so, of course, we emptied the circuit and everything looked good after we removed the water. So a lot of that noise that you're seeing, garbage in, garbage out, a lot of that noise you're seeing, even though you're using a proximal flow sensor, could be the result of something that's going on in the circuit as well. And this is a patient who was actually on ECMO, had relatively low lung volumes, and everybody was super confused about all these little kind of artifacts that were occurring at a very regular frequency. And so I think with low lung volume, the lungs are a low pass filter, and with low lung volume, you get more of the cardiovascular effects affecting your airway graphics, and not just pressure, because obviously our flow, because this patient had a flow sensor, it's a little more pronounced on the flow time scalar and less pronounced on the pressure, which is measured back at the ventilator. And so you can even see this in the volume waveform where you get these little jagged. This patient obviously had a very active precordium on ECMO, low lung volumes, and not too low, but nonetheless, the patient had a very active hemodynamic component. And so if you start to see a lot of regularity in your waveform, that could be the result of the heart and not necessarily the lung. And so the heart can trigger a ventilator. We know that. We've done apnea tests on patients, and we've seen that, if they're on dopamine or epi, that, obviously you can trigger a mechanical ventilator because it's all within the same cavity, right? The heart's beating away. That can cause some changes in pressure and volume and flow within the actual trachea that will trigger a ventilator. And so, keep that in mind when you're taking care of these patients. This is another really good example of a airway graphic that was a little misleading to us. This was a neonatal patient who was actually being supported by volume guarantee. And so if we were to look at this, we would think, all right, that's the mandatory breath. Yeah, definitely, for sure, right? Because it's larger. And this patient's in SIMV, they're getting volume guarantee. And every one of these breaths right here are going to be pressure support, right? Because they're smaller. No, that's not the case. This was a patient who actually weaned and did quite well. And this is why we don't use pressure control SIMV as much. We tend to use AC for VG in the NICU, because this is the pressure support breath here, because it's brown and it's decaying down to a certain peak flow, 15% of peak flow. And we're getting more support, pressure support breaths than we actually are with the VG breaths. And so, you know, this is another good reason why I probably wouldn't use pressure support in a patient, especially when we're trying to wean them from a ventilator. I actually much rather prefer to use AC, because every breath has a flow and a tidal volume and a corresponding reduction in the pressure. And so if they look good, you could extubate from that, right? And so, you know, this can be a little bit confusing, but you see that the distinct brown flow waveform here indicates that that's a spontaneous breath. And so that patient actually was extubated, but there was a lot of discussion and debate about whether this was a SIMV full support breath and this was a pressure support breath. I'm like, well, there's no pressure there. And you've set your pressure support at 12. Those are VG breaths. And that's a pressure support breath. Anywho, so I just wanted to kind of point that out to all of you. Make sure that your patient is suctioned. So when you're evaluating the airway graphics, make sure that they've actually had their airway suctioned. I think that's so important, because there's obviously a lot of respiratory artifact that can occur when gases burble through an airway during inhalation, and then they burble back out on exhalation when the airways kind of shorten and become smaller in diameter. And so, you know, this was a pretty alarming airway graphic, but we went in, we suctioned, and you can see that, you know, in this patient who had a bronchoscopy, they actually had to go down and remove the secretions from the airway with an assisted bronchoscope. And that patient did much better. And so, you know, this kind of just speaks to the fact that maybe we should be suctioning our patients before we fully assess what's going on with their airway graphics. And so abnormalities, air leaks, overdistension, increased expiratory resistance, the inspiratory time, which I think is really, you know, one of the major drivers on determining how patients respond to mechanical ventilator support, which we'll speak of, airway obstruction, Asynchrony, how the patient interacts with the ventilator, inadequate trigger sensitivity and adequate pressure support, poor compliance, all factors that, you know, definitely lead to changes in your airway graphics. And so in a patient who has relatively normal resistance, the flow goes into the lung, and then based on the inspiratory time, exhalation occurs. And, you know, what goes up must come down, right? Or what goes in must come out. And so that's what we teach people, is you got to adjust your inspiratory time and your respiratory rate so that you allow all of the gas to come out of the lung as best as possible. And maybe you need to adjust the PEEP in order to achieve that as well. And so if you have someone who, you know, say is in pressure control at the same setting, and they develop increased airway resistance for one reason or another, maybe they need bronchodilators or to be suctioned, you'll see that the flow goes in and then it kind of truncates right here. And so the peak inspiratory flow is achieved, and then the flow gets a little more truncated. So it's higher above baseline in this case. That indicates that they have a longer time constant in the lung, and they require that pressure to be held in there longer in order to get a more flow into the lung and to achieve a higher tidal volume. Now, in the absence of, you know, secretions and bronchospasm, I have seen some patients who have, you know, been transitioned to subacute ventilators in the NICU, then they make their way down to the floors and they're still on a neonatal inspiratory time, and people wonder why they got to use a pressure of 40 because you're not allowing enough time for that gas to enter the lung. And so I've actually increased the inspiratory time and allowed the flow to go in and then come kind of closer to baseline. And, you know, miraculously, the tidal volumes increase because you're providing more flow over that time for a given pressure, and we were able to wean the pressures way down. We almost cut the pressure in half. And so keep that in mind when you're adjusting your inspiratory time, because you obviously want to allow the lungs to fill as much as possible. And we're seeing more and more of these BPD kids who have these super long time constants because they have extremely high resistance. And so, you know, the 3 to 5 time constants, you know, keep in mind that you're filling not only the circuit, but also the patient's lungs and their airways. And so you may need to use these longer inspiratory times. And in essence, you may reduce your peak pressures or reduce your pressure control level because you're allowing more time for those lungs to fill. And that could ultimately reflect in an improved CO2 efficiency and ventilation efficiency in the end. So I'm going to ask someone, have you ever seen this before? you've got this chronic kid that's on a ventilator. They were born at 24 weeks and they've been on the ventilator for a long period of time. And you go into the room and every once in a while they're desaturating, they're becoming bradycardic. And you may see something like this if you're actually looking at the airway graphics. And you can impress a whole lot of people if you can actually come in there and say, wow, I think something's going on. And by looking at these airway graphics and looking at the underlying asynchrony or poor patient ventilator interaction, you may be able to show the neonatologists and the folks at the bedside that it looks like there's a flow limitation. For some reason, the flow is going in. We should be using a slightly longer inspiratory time in this case, potentially. Flow's coming out, but then there's this choke point that's being created, and not all the flow comes out because it goes down to zero, and then maybe there's an active exhalation. It's likely that in these cases, if you were to actually look at the flow volume loop, you see the flow going in, but then immediately after peak flow, when there's less pressure in the lung, the airways start to collapse. And so that's very characteristic of especially in these BPD kids, of tracheomalacia or bronchomalacia, because you've been ventilating this kid for over a month, and compared to their distal airways, the distal lung units, the airways are going to have a much higher compliance, and so you may be exposing those airways to the higher pressures, and that could actually lead to kind of an inelastic component and poor development of the cartilage that may result in this kind of unique looking waveform that could indicate that you have collapse. And so, maybe you've given a bronchodilator treatment to these patients and you're seeing it more. Well, that's because, that you have bronchial smooth muscle in your trachea and your distal bronchi or your main stem bronchi. And if you give albuterol, sometimes that can increase the level of collapse in there because you're bronchodilating. And so definitely something to kind of keep your eye on. So this is a video back when we had our via ventilators that shows a patient who had pretty significant tracheomalacia. So you'd go in the room and they'd have these spells, and the patient at the time was on 5 of PEEP, and we'd see that the flow would go in on the flow volume loop, but then immediately after the peak flow, when pressure was reduced in the lung, you'd see that there was this pretty significant collapse. And looking at the PV loop, there's quite a bit of distance between inhalation and exhalation, which typically indicates that the patient has high airway resistance. And so, this was a patient who actually benefited from having their PEEP increased. And so a lot of people want to come in and place bronchoscopes, and this was that patient. And if you look down into the airway where you see light, that's the posterior membrane collapsing. And if you look down into the distal lung units, you can see that a lot of the bronchioles are collapsing as well. That's at a PEEP of 0. But when we add a PEEP of 10, you can see less light here. And during the bronchoscopic evaluation, there's less collapse, but still you can see some of those little smaller airways winking at you downstream. And so anytime that a patient has an active exhalation or they increase the pleural pressure, it's likely that those airways will collapse. And so by placing this patient on a PEEP of 15, who had pretty significant BPD, you can see that the actual airways stay open, but there's still a couple that are winking at you down there and trying to close. And so I think, with a bronchoscope, you create a choke point, and, it's not as realistic as a patient who doesn't have a bronchoscope in there. So I'm not sure that you really need a bronchoscopy study to be able to identify tracheomalacia. And in fact, we could rely on airway graphics instead of putting a scope down there and getting something that's kind of misrepresentative of what's truly going on a day-to-day basis. This was another infant with airway obstruction who presented with a viral infection. We knew nothing else, just the fact that they came in with a viral infection. Their CO2s were relatively normal. We started seeing these clefts, these little interruptions and the swing of the magnitude of the end-tidal CO2 waveform. And I remember our department director, Dave Crotwell, went up there, and we were both up there, and he's like, I'm sorry, but something's going on exhalation where it's impeding gas flow out of this patient, and it's very regular. So that may actually be, you know, something, you know, underlying. Maybe it's a tracheal sling or a PA, you know, inaudible vessel that's kind of positioned itself over the tracheal airway. And sure enough, this was the heartbeat that was being observed in that flow waveform, and that was the result of some vascular compression because of a congenital abnormality. In this case, I believe it was a aortic arch that was compressing the trachea. So, you know, a lot of what we do, and you know, that's why I really emphasize on trying to make sure that your airway graphics and your analysis are appropriate. Get the water out of the circuit, suction the patient, and then get a good look at, clean look at what's going on. And if you see these regular heartbeats and the artifact that has, especially in the flow sensor, because it's very close to the patient, then you can appreciate that maybe there's something other than the lungs that could be impeding the flow coming out of the lungs. So very important clinical tool. And our department director was, you know, kind of the guy who made it so that this patient went down to the cath lab, and sure enough, they had a pretty significant underlying cardiac lesion that needed immediate surgical repair. And so good on him. So this is what Asynchrony looks like, right? Normally, we shouldn't see a patient struggling on a ventilator, and this is a patient that's in fact struggling on a mechanical ventilator. Every time that they try to initiate a breath, their chest wall is, you know, sucking in, and they're creating retractions, and there's high pleural pressures that are being generated. That is not how patients should actually look when they're being supported by a ventilator. And if they are, then that's really kind of on you as the clinician. This is a patient who looks pretty good, and every time they trigger a breath, they get that breath immediately. I mean, these ventilators, especially when you use the proximal flow sensors, are super fast and super responsive. I mean, it doesn't matter which one you're using. They all should be able to respond to these very sensitive changes in pressure in the lung that result in a change in flow that allow us and these children to actually trigger the mechanical ventilator. And so whether you realize it or not, this poor ventilator interaction is a major problem for patients on the ventilator that we ourselves can basically try to eliminate or avoid. And so in patients who have very leaky endotracheal tubes, which there are many, obviously, they outgrow their tubes. And, you know, depending on the ventilator you're using, you should have good control over the triggering based on the leak detection and the triggering algorithm that you're applying with your system. And so this actually is a patient who the nurse turned and, you know, called respiratories to come into the room. And they're like, well, the respiratory rate went from like 40 up to 80. I'm not sure what's going on. And the transcutaneous CO2 is in the 20s. And so, of course, you know, you come into the room, and at the time, this is 15 years ago, we have to constantly adjust the flow trigger. In this case, you know, you start to see regular patterns that accompany a leak. That usually indicates that if you have, you know, these triggered breaths and the patient didn't look like they were triggering them, that was an auto cycle, an auto trigger as we know it. And that's not a good thing for babies, you know, because they're set on a certain pressure or volume at a certain frequency. And we don't want this noise to be driving our CO2 down, because now they're getting all these fully assisted breaths that are going to drive the CO2 down, because we know that could lead to some cystic brain lesions and poor outcomes in patients, periventricular leukomalacia, cerebral palsy, all those things. And so I think the ventilators have gotten better. Alternatively, or conversely, in patients who don't have their trigger set appropriately, maybe this is the same patient, they increase the flow trigger so that they would reduce the auto cycling, and then maybe the nurse reposition the patient. This usually indicates that a patient's trying to trigger breaths. So you see that, you know, there's no color change and no support that's being provided. That's equally disastrous, because they're not getting the support from the ventilator, but they're still trying to make a trigger effort and having to overcome this extremely high flow trigger setting. And so, you know, keep that in mind, that if you're not seeing assisted breaths, if you're in SIMV or AC, and the rate goes down, then they're not getting support. And so you have to be mindful of what your flow trigger is set at. You need to make it more sensitive, in order for that patient to be able to trigger. And so dysynchrony really is an asynchrony or poor patient ventilator interaction, whatever you want to call it. Those aren't actually words you can find in the dictionary. Really, again, if we provide perfect synchrony with the patient, with the breath, then, we will ultimately have to use less sedation and get them off the ventilator sooner, quicker. And so this is a patient who is obviously distressed. There's a lot of differences in the level of pressure that's being provided. There's differences in inspiratory times. And so this is typically what it's going to look like when someone's not interacting well with the ventilator. And so a lot of that has to do with excessive inspiratory time. And, so when we have an excessive inspiratory time, the patient gets the breath, but then naturally they're going to want to push that breath out. And so that could lead to gas trapping, that could increase our risk for hypercarbia. It's obviously going to show that the patient has increased work of breathing and fighting on the ventilator. The same could be said about an inspiratory time that's not set appropriately. And so, the inspiratory dysynchrony or asynchrony that's associated with the prolonged inspiratory time looks like this. And you really have to look at your flow time scalars: inspiratory flow, expiratory flow. If they're doing something like this, then it usually means that they're trying to push the breath out because they're ready to exhale. And we've set that inspiratory time too long, and that results in an inspiratory pressure plateau at 0. All right. So if you can reduce your inspiratory time, you could potentially allow that patient to achieve greater success with interacting with the ventilator, but also degas the lungs a little bit better as well. And we saw that one before. Oops, sorry, I think I went backwards, so we'll jump forward. And this is another case of auto triggering on our newer ventilator. And I think we don't really see this unless the leak is, in the 90s or to 100. But then, we can go in and obviously be able to adjust the flow trigger to satisfy that. But it's interesting to see that there are fewer ventilators nowadays that are resulting in this type of auto cycling. And so just another example. This is a nice waveform that shows what excessive inspiratory time looks like. And so if you have a patient who's in pressure control or volume guarantee, and you see that the inspiratory flow goes in, but then there's this 0 pause pressure or 0 flow, that means the pressure or the flow and the pressure is being held in the lung. The patient may want to exhale. And so based on our standard ventilator management guidelines for NICU, we want to try to minimize this effect right here where you get the back porch. You don't want a deck. You could have a small back porch, but in essence, we want to try to allow the patient to breathe in and then breathe out immediately. But it's also important to kind of look at your tidal volumes and their overall work of breathing when doing that. And so this is a patient who actually had this inspiratory pause being held in the lung, and they were heavily sedated postoperatively. And then when they woke up, that's when they started to have this significant dysynchrony. And so by reducing that inspiratory time, we were able to allow them to interact with the ventilator a little bit better. So inspiratory time is everything, right? You want to allow the circuit to fill, you want to allow the lungs to fill as well. And so excessive inspiratory time is as important as insufficient inspiratory time. And so again, this is a patient whose lungs fill, and then we truncate the flow immediately by using too small of an inspiratory time. And actually by going up on the inspiratory time, we allow the flow to come down closer to baseline, and that could obviously result in improvements in tidal volume and synchrony and reduction in the peak inspiratory pressure. Super important stuff. Rise time, a lot of ventilators will provide or allow you to actually adjust the rise time setting. And, so if we're using a rise time, and I tell people, leave this alone and, try not to adjust the slope. And in this case, the ventilator we use, it's called a slope. And typically we want that flow to be achieved up front. We want them to get the flow when they initiate the breath, and we want their lungs to fill, and we want to be able to provide this higher mean airway pressure with our decelerating wave flow pattern. Now, if you are to adjust your slope, then basically what that does is it takes your inspiratory time and distributes the flow later in the breath. And so this basically flow limits the patient, and it looks more like a volume control type breath in this case. And so there really aren't a lot of good situations where I would suggest using a higher slope value than 0. You know, we used to have a lot of chatter in the circuit, but that was before proximal flow sensors. Back using the Servo 300, we would have a patient take a breath, and then all that flow is dispersed into the circuit, and it creates this chattering event. And so we would have to adjust that in some ventilators. But now with the flow sensors and, you know, having ventilators that have less aggressive flow algorithms for supporting neonates, I don't think we really need to set it much. I have, however, found that in some patients who have excessive leaks, that if you provide this kind of slower flow based on the slope, that sometimes they have improved expiratory tidal volumes because you're blasting less flow at that leak and getting a better distribution of the gas in the lung. So this is another thing when someone's in like full pressure support, or even if they're intermittently being supported by pressure support ventilation. Typically, if I go into the room and I start to see a figure 8 in the pressure volume waveform, I can almost immediately identify the fact that, you know, maybe they don't have enough support. And so this was a patient who was having a figure 8. Typically, that should look like a football that's ready to be punted, right? And, you know, if it's starting to have what we call negative hysteresis and it's figure 8, that means the patient's flow demand exceeds the pressure that's being provided by the ventilator and the flow that's being provided by the ventilator. So by simply going up by even a small amount of pressure support ventilation, you know, you can actually see that there you eliminate that negative hysteresis, and you start to see that during inhalation you now are getting the pressure and the volumes you want, and it's a much cleaner graphic. I can't tell you how many times that has come in handy for me, both for pressure support and for SIMV. This is an example of a patient who is on VG, and we have a very active management guideline here where a majority of the patients are supported in pressure AC with VG. We like that because you don't have any pressure support. It's kind of confusing people. And so if a patient's pressure's weaned down, that usually indicates one thing or two things, and it could be good or bad. In patients who actually have a weaning in the inspiratory pressure, that usually indicates that either their tidal volume and the pressures that they're being provided are not enough. And so in this particular case, we got a neonate with a bell-shaped chest cavity, and, you know, we got air bronchograms and low lung volumes. This kid actually wasn't doing so well and had reduced saturations. And so in this particular case, they were trying to tell us something. They wanted a higher tidal volume than what was set. And so that was at 14.4. They were trying to tell us, well, I want 17.5. I'm not ready to come off the ventilator quite yet. But if I was, and I didn't have an oxygen requirement, and, you know, my work breathing wasn't super high, then you could extubate me, right? Because you're basically getting CPAP right here. But in this particular case, when we increase the tidal volume, then that obviously naturally provided more pressure to this patient who wasn't ready to be extubated. And you can see that their respiratory rate comes down. The lung inflation looks much better. You know, obviously less presence of air bronchograms and low lung volumes. And that's because we increased the tidal volume. So that's such a key component of managing patients on VG, because if you're not updating the tidal volume, or they have changes in anatomic dead space over time, then they will declare to you that, you know, I am not doing well on this mode at the particular settings that we have. And just by slightly going up on that tidal volume, we increase the pressure enough that that patient had better inflation and better gas exchange, and overall looked better. Initially, you know, looked a little sick, and we thought, you know, maybe we have to put them in pressure control, but you're not able to target those tidal volumes specifically in pressure control, and that's not always a good thing. And so just by going up on that tidal volume, come to find out we didn't update the tidal volume in a few weeks, then that patient looked better. We can use the airway pressure and volume graphics with regard to loops to actually look at bronchodilator effectiveness. And so, you know, in a lot of people will try to tell you that, we haven't been able to do this in the past, but, if you look at, if you're able to go in and actually capture a pre-bronchodilator flow volume loop, you will see over time, and I would assess this 20 minutes after you give the bronchodilator, that there is some improvement, obviously, in the flow volume loop post aerosol. And so, you see here that the inspiratory flow goes in and then exhalation occurs, and then it kind of takes some time to get out, and so that's usually the PEEP exhalation valve coming in. But if you look at your peak expiratory flows, and this is another example of it where this patient had a really good bronchodilator response. If you look at your peak expiratory flows, that's when the valve gets out of the way, and we're not trying to regulate PEEP at all. But if you have curvature like that and you're able to avoid some of that curvature and increase your peak expiratory flow, then that's usually a good thing. Job done. They have a good bronchodilator response. And so, if you look at your pressure volume loops as well, you see this big old belly right here. I know Dave Crotwell used to call that a gut. If you can eliminate some of that, which we did in this particular case, this is all airway resistance. And so that pressure in volume guarantee was actually much higher, but by giving a bronchodilator, we brought the pressures down to get, a similar tidal volume. So super important stuff. With regard to compliance, I think we have to really take into consideration that it's difficult to be able to make assessments on pulmonary compliance in these small patients, based on the fact that the pressures measured back at the ventilator. We're not doing a slow inspiratory flow to achieve, this compliance measurement. And so they get small ET tubes. And so it's tough to look at compliance curves in these patients. But generally speaking, I think, the textbooks will tell you that, if you're underinflated, it's going to require some pressure to open the lung. Once you get that lung open, it's in kind of that sweet spot, you're going to have kind of a linear increase in the amount of pressure, or for the pressure applied to result in a increase in the tidal volume. But then there's also a second part of the curve where the compliance isn't as good. And, so you never want to see anything flat necessarily, but again, approach these pressure volume waveforms or loops with a little bit of trepidation, because you're taking so many other things into account, the ET tube, the airway resistance, so on and so forth. And so this just represents a patient who, had, relatively low compliance. So 0.2, this is a patient with RDS, and you can see that the pressure waveform is kind of leaning downward, and there isn't a lot of volume for a given pressure that's going into the lung. Apparently our PEEP was set appropriately because there wasn't excessive pressure being required here in order to get a change in volume. But, obviously this patient has diffuse bilateral infiltrates. The dynamic compliance is fairly low. And, also keep in mind that if you're looking at this portion of the curve right here, sometimes the C20 over C-din, which is going to look at the last 20% of the curve, that's your bird's beak. So if this value is actually greater than 1, or less than 1 rather, then you may have, reduced compliance at the later part of the curve. And so in this particular case, that wasn't truly what was going on. But then, when we gave, so that was the pre-surfactant pressure volume loop. After we gave the surfactant, obviously the lungs really improved. And you can see that when we applied pressure, there was a pretty dramatic increase in the tidal volume, and the compliance improved, so on and so forth. Tidal volumes got better. So, we can use these tools. And here's the pre and post surfactant showing the pressure volume loop and the flow volume loops. We can use these tools to evaluate the actual effectiveness of different treatments. I know that we're running out of time, but I want to just briefly touch on non-invasive ventilation. Obviously, that's something that we're doing a whole heck of a lot of. In fact, ventilators may be in the back room because of that, but there's still some good information that you can glean from your pressure waveforms. This represents a patient that was in NIPPV with nasal prongs, and these are the mandatory breaths, but you can see that the patient's making efforts right here in the pressure waveform. Even though we don't have flow and tidal volume, you can appreciate that the patient's making efforts, and if we need to make adjustments in the respiratory rate or the pressures or the inspiratory times, then we can kind of rely on these graphics the best way possible to try to synchronize with their efforts if they have high work of breathing. There are a number of other ventilators that are available now that don't require the use of a proximal flow sensor necessarily for non-invasive ventilation, and are able to calculate the leak and be able to correct for that and take into account the circuit compliance factor to allow for synchronized breathing based on the flow measured back at the ventilator expiratory valve. And so people have come a long ways with non-invasive support. Neurally adjusted ventilatory assist, that requires the use of a catheter. We're looking at the electroactivity of the diaphragm, and that kind of provides some input on when the breath is initiated, when it's terminated, and how much support they get when the patient initiates the breath thereafter. Thank you.